We now begin with the first symposia of day 2 focused on empowering women in pharmacology to make a global healthcare difference. Empowering women in pharmacology is crucial for advancing global healthcare by promoting diverse perspectives and accelerating innovation in drug discovery and therapeutics. To guide this prestigious session, I have the distinct honor of inviting our session chair, Dr. Shelja Rao, to please come on the stage and take your seat on the dais and officially open the proceedings of the session. We have Dr. Urmila Aswar too with ma'am. Dr. Urmila Aswar, Professor of Pharmacology at Pune College of Pharmacy, Bharati Vidyapeeth, deemed to be University Pune, has over 18 years of experience in preclinical pharmacology and drug discovery. Her work focuses on natural products and their therapeutic potential in models of diabetes and allergic rhinitis. She has published over 30 peer-reviewed articles and received honors including the Acharya Award. Dr. Aswar also contributes actively to scientific collaborations. We welcome you here, ma'am. Dr. P. Selja Rao, Professor and Head of Pharmacology at Tigala Ram Reddy College of Pharmacy, has 19 years of academic experience. She has received 2 international awards for oral presentations and previously served as assistant professor at Saudi Arabia. She is also a CPCSCA nominee appointed by the Government of India. We welcome both of you to chair this session, ma'am. I would request you to please kindly introduce our first speaker, Dr. Chetna Desai.
So, before initiating this program, so let me tell you that this is first of its kind of symposium where women are conducting and women are the speaker. This program is dedicated to the forum Empowering Women in Pharmacology to Make Global Healthcare Difference. Women, as all of us, we know that they are the threads that weaves the family, communities, and societies together. They are pillar of strength, shaping the world with wisdom and compassion. We decided to make this forum starting of this year, and now we have this in IPSCON. The major consideration under this forum were empowerment and support. We want that women pharmacologists should share their experiences, challenges, and success. Career development, training, giving the training to the fellow pharmacologists, mentorship to the young women pharmacologists, networking and collaboration, and the most importantly, we have encouraging the women scientists by giving them Women Pharmacologist of the Year Award. So this is first time we are doing it, and right now we have with us the first speaker, Dr. Chetna Desai. Dr. Chetna Desai is Professor and Head, Department of Pharmacology, BJ Medical College, Ahmedabad, a distinguished expert in clinical pharmacology and health profession education. She has been actively involved in teaching, research, and training since 1990. Dr. Desai has served as a resource person for national organizations including CDSCO and Pharmacovigilance Program of India. She has guided several postgraduate and PhD students and contributed to curriculum development at Gujarat University. She is recipient of many awards. Dr. Desai has also delivered prestigious orations such as Dr. S.B. Pandey and Dr. R.G. Kar Memorial Oration. And we all know that she has been the chief editor of Indian Journal of Pharmacology for a long time. So may I request Chetna ma'am to join us?
Thank you, and Congratulations and huge thanks to the organizers for thinking of this lovely session. I was just wondering that how come I fit into this session where the topics are so diverse. But then I saw one common phrase, that is women and women empowerment. And I'm proud to say that in a country like ours, I too have experienced women empowerment, and no better way to organize this particular session by having two lovely ladies as our chairs. And today I'm going to talk about challenges and facilitators for adverse drug reactions and MDAE reporting. Part of these I have also delivered at my S.B. Pandey, Professor S.B. Pandey oration. And you might wonder that why do I keep repeating? The reason is very simple. All through my 3 decades of pharmacology, I have been working on pharmacovigilance and health professions education. So anybody who knows me would know that this is what really I'm passionate about. So this is not going to be merely a textbook lecture. Rather, I'm going to share some of the experiences that we have gathered over these 3 decades, plus some literature search that we have carried out. And it's going to be more like, sort of do's and don'ts, or what we could do and what we cannot do for to face the challenges, and how we can tap on the facilitators for ADR and the recently developed MDAE, that is Medical Devices Adverse Events Monitoring. So I come from BJ Medical College, Ahmedabad, a very old, one of the older medical colleges in the country. And our journey in pharmacovigilance has been much before PVPI came up, as well as the National Pharmacovigilance Program. And I see one very senior mentor who is here, who has been associated with both the programs, Professor Gupta. And we began I started my first case report in 1990 as a case report of SJ syndrome with sulfadoxine pyrimethamine. And I was just listening to Dr. Kulkarni. She said that it's very important that we need to be aware about what patients suffer from. It's not just about textbooks. So over a period of time, our center developed from a National Pharmacovigilance Program center to AMC in 2011 for the PVPI. And then later on, we were designated the RTC, that is a Regional Training Center, and now recently we also are the MDAE Reporting Center for the MVPI. And the journey goes on. In 2008, when I was associated, or even otherwise, with Indian Journal of Pharmacology, just a correction, I was not the chief editor for a long time, I was only for 4 years. Right. So the Indian Journal of Pharmacology, we published a special supplement on pharmacovigilance, in which we first shared our pleasures and pains for running a pharmacovigilance center, because that was also the beginning of our foray into the pharmacology and pharmacovigilance, sorry, as a department. Today, I am happy to say and proud to say that the pleasures are more, the pains are lesser. And this journey has seen several ups and downs, but more ups than downs, and the journey hasn't ended. We have had a lot of capacity building, lot of upgradation of our own self, learning from others, and now we launch into the technical aspects and the artificial intelligence, which tells us that nothing stops. We have to keep on learning to upgrade ourselves. We all know that PVPI is all to do with drugs. Focus is on adverse drug reactions. In India, we use the MEDRA coding for submissions. We report to the PVPI, and timelines are quite mandatory for SAE reporting, especially when they are regulatory in nature. The medical devices adverse events and the MVPI is a relatively recent development. It has been felt that malfunctions, user errors, performance issues, different seriousness criteria, etc., they matter, and hence they need to be reported. We use device terminology in that, and the manufacturers often must also repeat with device specific timelines. So the SOPs for MVPI is also being built up, and now we are having more and more AMCs, I mean the MDAE reporting centers coming off in the country. But we know adverse event reporting is critical, but why? over a period of time we have realized that the underreporting is still an issue. And this is not something to do only with India, it's a global phenomenon. The percentages are not changing. The numbers may be changing, we may be having more number of reports, but yet the percentage of healthcare workers or the healthcare professionals who are reporting still needs to be brought up. Also, this is about ADRs. About MDAs, still the figures are lower because it's a relatively new concept. So this is a significant global problem, and just like any other situation or problem, we need to do a situation analysis. Over a period of time, not only us, but several AMCs and PVPI as well as the RTCs have realized that PV, pharmacovigilance and material vigilance is not just about reporting adverse events. There are so many subtle and overt roles and activities. We need to identify and recognize barriers which are very unique to your own center as well as to the entire country. We need to plan interventions to overcome, and hence it's an ongoing process where the changing the attitudes, researching and moving from an activity to objectionable information and data. So these are the broad barriers and challenges that I have thought about, and we'll just look into some of these. Major one is underreporting, of course, and when you want to understand what is underreporting, we need to know who are the stakeholders. So obviously the stakeholders are all healthcare professionals. We started with physicians, then we added nurses and pharmacists also to our basket, and then we spread out to biomedical engineers for MDAE reporting, and now we have consumer reporting also. Of course, in clinical trials, we have the manufacturers and the marketing authorization holders, and patients and caregivers. These are the newer stakeholders for reporting. And each of these have different roles to play, but eventually what matters is how is the reporting done at the programs and what are the regulatory actions we take because of the ADRs and the MDAs that we see. This is just an illustrative data, but it tells us that these are the various types of stakeholders that we see, and the percentages vary from country to country, but all said and done, we still have a major chunk of reports coming from the clinicians, and then of course we have nurses, pharmacists and other healthcare professionals, and now we have added the patients and consumers to our database. We actually started a situation analysis in 2011. We did a situation analysis by carrying out a CAP study, and this CAP study, we also shared the questionnaire when we published this CAP study, and it has been adapted by several people all over the world. And this has been used, I'm not saying this is the only CAP study that was done, but somehow we saw that this has been cited at several publications. But what did our situation analysis tell us? It told us about several factors that may discourage prescribers from reporting ADRs. And believe me, 2011 to 2025 today, these factors still remain relevant. To what extent? That may vary, but they still remain relevant. We'll come back to this later. Then we focused on nurses, nursing professionals. And of course, I'm not mentioning my reports here, my results here, because then it would look like as if we are the only people who did the work. But then there were other publications across the world which basically told that there is a consistently positive attitude towards reporting, but a significant gap in knowledge and practice. That is what we need to correct. So these have been found to be the various barriers. One is lack of knowledge, unfamiliarity with the reporting system, uncertainty about what to report, then professional attitudes, then fear of consequences. This we may put it under the carpet, sweep it under the carpet, but it's very important. Clinicians or healthcare professionals, fear of consequences. I'm sorry. Etc. is okay, but we are also focusing now on inadequate IT system and lack of feedback. Sorry. So we have done certain educational interventions on ADR reporting, And what we have found is this. I would just request you all to go through it so that I can take some rest. All right. I would like you to focus on the last sentence which says that cost, organization support and feasibility should be taken into account while implementing these interventions on a long-term basis. Now, these are the challenges that we faced, and these are the solutions we tried to find. Some of them are quite obvious, but I would like to focus on those which are marked in blue and purple. We developed the QR code system, the reference portal, the drop boxes, the notification forms for nurses, and also we focused on personal communications. What else did we do? We researched on this new concept known as trigger tools. The trigger tool method for early detection of ADRs. We carried out this trigger tool research in 3 major departments. If I'm permitted, can I take it a little later? Can I? I'm very sorry about this, but I guess it's the weather. Let me try to finish, don't worry. No, it's okay. So what we saw is that we have these preliminary trigger tools, and we observed these preliminary trigger tools in our own setup. We narrowed down the trigger tools to some few ones which matter in our system, and we distributed this knowledge about trigger tools to the reporters. Trigger tools basically help you in early detection of adverse reactions. We adopted this, although this is not a very good, well-explored method in India. We tried to simplify the reporting system. We tried to prioritize reporting by building this reporting into our reference portal system of Civil Hospital Ahmedabad. So all the clinicians who came across an adverse drug reaction, they reported this adverse drug reaction into this reference portal. It was only a notification. You can see the fields here. And this would come to our department, and then we would go and, look at the details of the report. So this really helped. For example, we have reported about 90 reports since 2021, since it was introduced. Another thing that we did was giving thank you notes at every National Pharmacovigilance Week, which is sort of feedback, as well as bi-monthly feedback to all the reporters regarding the ADRs that they have reported. Something that we learned from marketing people, give reminders. So during the National Pharmacovigilance Week, we introduced these reporting reminders. 1 year we gave them the mugs, later the pens. But what does this contain? They contain the scanned QR codes. What the reporters are required to do, just scan the code. It takes them directly to the notification form, and they can just fill in the details, and then we follow it up at the back end and visit the wards and take the reports from the patients as well as the reporters. So that way the reporters did not have to look into the ADR reporting forms or search for the ADR reporting forms. This really has worked well. We installed ADR reporting boxes at various places. And also we were concerned about this culture of safety, how to build a culture of safety, which is actually quite important. And what we saw that When there is no gain, there is no pain. The reporters and the clinicians need to know that by reporting, it will help them. There is no legal liability and concerns, and all this we could manage by education and training and giving a supportive organizational structure. We went out to the OPDs, we also educated the consumers, and we also had good media support. What we need to do further is overcome some technical barriers, and this will address some of the challenges that we face, like incompleteness of reports, coding challenges that we have, and uncertainty of the causality. And also, in our setup, the electronic health systems or records are not very siloed. They are in silos. We need to integrate them with the reporting culture, reporting system, and we have several diverse sources of data which need to be streamlined. So we need to see that how we are able to aggregate all of them. So we need to use the digital enablers for faster and more complete ADR and MD reporting. And AI can be used for case processing and signal detection. We need to integrate the EHR and auto-populate them. And these are the few actionable strategies to improve the ADR and MDA reporting and reduce the reporting burden, be it the private hospital, private medical colleges, or the general hospitals, or even the private hospitals. Please remember that low reporting is observed in these setups. When it comes to marketing authorization holders, low reporting is not so much of an issue. So we need to integrate into the curricula, have hands-on workshop. We need to redesign the processes and also start using technology to implement EHR integration, start using mobile apps, which has been started with by the PVPI, and AI triage to reduce the burden. So these are some of the practical tools that could be used: reporter checklist, notification forms, standard templates, decision support in case of when they are not very sure about the causality, serious adverse event reporting, whether to make out whether it's really a serious adverse event or not, rapid feedback, especially when they are not sure or when the fields are incomplete, scaling the reporting into routine clinical practices, and shared reporting pathways where single submission route is there to notify hospital safety team and MAH regulators. So these are the various interventions that I've talked about. And then how do we measure what we do? So there are some key performance indicators, like what is the volume of reports, the completeness of the report, the timeliness of the report, the follow-up rate, and we need to monitor these KPIs monthly and escalate whenever any metric drops down below the targets. So these are the few indices that we need to use. When we began, we used to just look at the first index. How many reports have we received? But now it's time to go to the remaining indices as well. Thank you very much, and very sorry about this intermittent disruption that I had. Thank you.
Thank you, ma'am. And it is the never go attitude of the women. And so your session was really very informative. You have nicely said about the information of ADR reporting, the changing attitude, and the situation analysis, fear of consequences, technical barriers, as well as integration of AI, which is very much needed in ADR reporting. Now, any questions if anyone has?
I'll be able to answer them, don't worry.
Yeah, I have a question, ma'am.
Yes, please. Which
Here,
side?
ma'am.
Oh, yeah, I'm sorry.
Why the ADR is not being reported in India?
Not reported in India?
No. Why it is not open up? They don't open up. They take so many multiple medications, but...
You mean the consumers or the physician or the clinicians?
Patients.
Patients? Yes. Oh, patients are still not aware. A country where self-medication is so common, OTCs are so common, do you think they will report ADRs? And plus consumer reporting has been introduced only a few years ago. So it will take time to develop. Do you know how many consumer awareness programs have we carried out for ADR reporting? Not many so far. But I'm sure that once we increase it, we might get them to report. So since the past 3 years that I know, the Pharmacovigilance Awareness Week, it has been focusing on consumer reporting. So eventually it will develop. But I agree with you, but right now it's low. It's very low.
Okay. Thank you.
Partly illiteracy, partly lack of awareness, ignorance, so many things. Yeah.
Lack of awareness.
Yeah. Thank you.
Okay. Thank you.